All right, so I have I was telling Kurt this morning, I have a work in planning, not a work in progress, that I want to present. And I see lots of folks here that I think would be able to give some input to this. And so I'm going to try to just talk for a hair over 20 minutes, and then hope that we have at least 10 minutes for input from all of you on this plan. And so I'm going to talk about just digital biomarkers, but for the purpose of two things. One is a cohort study that we've been planning for some time now and think we finally have figured out, and that's going in early March. And then the other is, if we're collecting all of these data for this cohort study, can we use these digital biomarker data, not just for that study, but also to work on the next generation of behavioral interventions in primary care? And so those are the two things I want to talk about. I'm actually not going to talk much about the cohort study. I'm just going to give you the gist of that because it's the foundation for the work on improving behavioral interventions. And that's where I would really like some help thinking. And so digital biomarkers for our purposes are social, behavioral, or physiological things that are captured through mobile or wearable devices. I'm not talking about the kind of breadcrumbs that Google might be picking up. We're deliberately giving people something to measure something. This isn't accidental through your life that we're capturing data. And then I'm going to talk about risk exposures, not so much risk factors, just to distinguish between things that are really dynamic and changing all day long versus things that are kind of more static. You know, if you have obesity, that's kind of a thing you have, but if you have high fat, high sugar meals, that's something that fluctuates and changes a lot. So just to make that distinction. Okay, so this is the start of this work came through Mike Weiner's leadership in our brain safety lab, where he's had the team putting together continuous glucose monitoring, physical activity and sleep tracking, every other or every third day, a very detailed dietary assessment. We have momentary assessments that we do through the phone to capture information about medications, timing, and whether or not they were taken. And so Mike's really created the foundation for this through that project. And we want to now think about using these for a larger project that would be a cohort study. And Mike's been focused on older adults with diabetes. For this cohort project that we would now do, we would focus on a midlife primary care population and with the interest in a better understanding dementia and Alzheimer's pathways from midlife on into later life. Much of the work in dementia now is moving back to midlife because there's evidence that the biomarkers are present as much as a quarter century before symptoms of dementia are present. So understanding better how are those early disease markers coming about is now much of what prevention in this field is about. And so that moves us way back into midlife. And with a focus on a higher risk population, which is what our focus will be on Eskenazi FQHCs, the federally qualified health centers. And those tend to be a pretty vulnerable population where there's a high prevalence of these risk exposures that we're talking about, where there's high rates. I think, if I recall right, there's 40 or 45% that have diabetes in this midlife range in those FQHCs. 60% or more have hypertension. The obesity rate is around 50%. So it's a very high risk population, and this is a group that has not been enrolled in the dementia, most of the dementia studies to date, which have mostly focused on older adults, but even those that have focused in midlife, they have been a very pretty low risk midlife cohorts. And so this is an opportunity to look at a very high risk group and track these exposures all day long and connect these to the biomarker evidence where we would have blood, fluid biomarkers, and we would have imaging biomarkers as well. And this would be a longitudinal study. So initially, this is a week or two of intense data collection. and then we leave people alone, and 3 years later, bring them back in and get these measures again. So that's the cohort study, and this is the digital biomarkers serve a big purpose in understanding those exposures and the connection to those biomarkers in that cohort study. And this is the team for the cohort study. Sue Gao is the will be the biostatistician co-PI, and Chris Callahan will serve as a clinical co-PI, and then Hugh Hendry's been very involved with us in thinking about planning this project. And then Mike will be involved, of course, because he has the experience through the hyperglycemia project. And Wan Zhu and Ching over in Biostats have done a lot of the data management of these intense digital data that we've been capturing in the brain safety lab. And that is a pretty intense process. And so their expertise and experience there is going to be critical. And then Bob Considine, Frederick Prasad, and Andy Sakin and Liana Apostolova are the biomarker and dementia experts. And then, of course, our staff, raise your hand. I think most of them right here, Philip and Mackenzie. I don't know if Denisha's here, and Jessica and Corey have all been doing a terrific job in this early work in our other studies as well. Okay, so that's the foundation for the digital biomarkers and the cohort study. But now if we have all of these data, we would like to apply them to something useful for the health system. And it turns out Eskenazi is at a point in time where they're thinking about how do we get more lifestyle-oriented, health-promoting focus into our FQHCs and be a little bit less disease-reactive and a lot more health-promoting. And so in meeting with Eskenazi leadership, they're pretty enthusiastic about us coming in, setting up in the FQHCs to capture all of these digital data, but then assisting them in using these digital data in the process of care, and most importantly, in thinking about next generation behavioral interventions. And so I want to give you now my thoughts about how we could do that, and see what you can give into the plan. Okay, so this is just a little bit of theory. This is self-determination theory, and this is the start of my 25th year here at Regenstrief. And the foundation of self-determination theory is that you have a context that provides you with autonomy, a sense of competence, and positive relationships. And that's what we all have here. This is what, in my experience of 25 years, the centers and the Institute has provided. When we talk about vulnerable populations, we often don't define what we mean by vulnerable. But I know in the Center for Aging Research, when we talk about vulnerable, much of the time what we have in the back of our minds is that they lack a context in which they have this critical foundation, either in critical developmental periods or in present time. They don't have this kind of autonomy and positive connectedness that's critical for optimal human functioning. And that allows one to then function to a level that you meet your own basic needs and perhaps those support those around you. And having that foundation is critical to being able to pursue goal-directed behavior and to persist in self-control, which is what is necessary to overcome these exposures, which are mostly habitual. It takes that kind of awareness, persistence, and self-control. And in a vulnerable population where some of these foundations don't exist and some basic needs aren't even being met, it's a very different challenge from what is most often pursued in the literature. So we have to, this theory is relevant to thinking about how we can manage in a vulnerable population to actually pursue behavioral interventions. But this is a very static theory. This theory has in mind that one experiences this and then has these things. But we know that this is changing constantly all day long. Your context is very fluid. And whether or not your basic needs are met or you have some core motivation to seek a basic need is very fluid. And your capacity for self-control as a result is very, very fluid. And so this is a theory that does not exist. But in my mind, this is how it might function. So this is, these are pistons tied to a crankshaft. And the behavior is what is sort of pushed out of this engine. And all of these factors are moving through time in an interdependent fashion, affecting one another. So if you experience social rejection, your basic need for social acceptance, that's a core human need. You're going to be driven and motivated to seek acceptance in that moment when you've experienced rejection. That is going to affect your capacity for self-control for some period to come, because self-control requires persistence, awareness, and attention, and many other things. And when you're driven for a basic need, that compromises your capacities for self-control. And the context is always changing too, so task difficulty is changing, and all of these factors play together to influence behavior. We didn't have these kinds of measures 25 years ago when I started here, but we do now. And so how can we now use these digital biomarkers, which capture better this dynamic process, and come up with some more effective and efficient behavioral interventions. So now I'll get into the plan here, which many of you will recognize. So we have this foundation of digital biomarkers that we will have on a large sample in the primary care sites, and it's a high-risk population. Can we use those digital biomarkers to then support teams that would address a specific exposure issue? So if someone's worried about sodium, a provider is concerned about hypertension. They might address sodium and smoking to pursue the problem of hypertension or high blood pressure. Another team might address nutrition for the purposes of weight management. And another team, Mike's team, is already addressing hypoglycemia, so capturing all these data around glucose variability and the factors that influence that to manage hypoglycemic events in older adults. There could be multiple teams like this, and these are Plan, Do, Study, Act teams. These little tiny circles here represent a Plan, Do, Study, Act cycle. And there's this new thing out there, and I'm not a huge fan of buzzwords, but there's this agile behavioral science in a few publications. And you really have to squint to see the difference between that and just a Plan, Do, Study, Act cycle. But I left the term agile in here because there is one thing that's different. So a Plan, Do, Study, Act cycle, you choose a target and you do all of your planning, and we're going to, in this case, we're going to assess traits and monitor states with these biomarkers. And then you decide what is your intervention going to be? How are you going to move this thing? And then you test it in very small sample, get feedback, make adjustments, test it again. This is the PDSA cycle. What's unique in an agile behavioral science process is this effort that the intervention you're putting into place is a very specific change lever. They make the case, and it's a good one, that behavioral science has had this package problem. You put stuff, you want to change some exposure or risk factor. You put together something and put it in place, and then 3 years later you see if the trial, it's a trial. You find out if it worked or not. But then you're working backwards to see, well, what was it in this thing that actually caused the change? That's mostly what's happening in the behavioral science field. And then we don't end up building very effectively a set of tools. So their case is be very focused and very specific about what that change lever is going to be, test that, be willing to set it aside if it's not working, or iteratively improve upon it if it is. And if you get to a point where it is working, then hold on to it, because it becomes a module that you could use in other interventions. And I think working in the vulnerable populations, we talked about some of the challenges, this really is critically needed, because most of the literature that's out there and the behavioral economic tools that are out there, those have been created in very not in vulnerable populations. And there are some reasons why they may not apply. So here, this is the core modules. This is kind of the unique thing about an agile behavioral science process. I'm going to start to give you the building blocks here of this process. So these are, you identify the lever, as I said. What is your behavior change lever? And there are multiple possibilities. You could be working on reducing the self-control burden that people experience in trying to change some behavior. You could tap into core motivators. And I like BJ Fogg, if you ever have a chance to look up his behavioral model. I find it one of the most compelling. It's one of the most easy. It's pretty easy to understand, and it's pretty compelling. And there's a lot of confusion about what is motivation in the field. He makes the case that really all humans through evolution are motivated for hope over fear, pleasure over pain, and acceptance over rejection. Those are the things we are all day long motivated to achieve. And then anything else requires self-control in managing those core motivators so that you can pursue something else. So that's critical to understand, and you might tap into those core motivators as you design your intervention. Accountability is a possibility, or change the workflow, or these kinds of things. And you want to be as simple as possible in your design here so that you know what you're testing, people know what they're experiencing, and you can hit it. And then critically, this is repurposable. If you come up with a behavioral module that works and you can use it again, that's what we're aiming for. So that then the next team that comes along doesn't want to do hypoglycemia, but instead wants to do a weight loss intervention. They know, well, in this population, this has some possibility. We can repackage this a little bit and put it to use. And that could happen over and over. And then in data analyses, with these digital biomarkers, I think until you start doing this, you don't realize how intense this is going to be and how difficult. In one person, there are hundreds of data points over just a 1 week period from all of these different digital biomarkers. And this team here in the hypoglycemia project has looked at these data in single individuals multiple times, trying to find patterns and relationships. And we've done this in our weight loss trial too, where we're getting all day long reports about when are you eating, where are you eating, who are you with. Just trying to make sense of that for one individual, let alone multiple, even hundreds of individuals, is a significant challenge and really takes good data management, good data analysis, and data visualization. And I think that's an area where we have to think cleverly about. And for this to work, for these modules to work, again, you have to have a threshold where you say, yes, it's working, no, it's not, let's move on. So you need to agree to that in planning. And I don't think you need to say too much here. We would be monitoring states. Those are some of the exposures, but they're also, where are you? What are you doing? What are your activities? What are your emotions in those situations? Things that you think may be critical for whatever intervention you have planned, but are very dynamic. And then some things are less dynamic and they need assessed, like basic needs. Do you have food insecurity or housing insecurity? And what skills do you have? Can you read a nutrition label? We know in our project that as many as half are unable to read a standard nutrition label and figure out how many serving sizes are in this container. So that's a critical piece of information to know in this population. Okay, and then finally, everybody knows that engagement is critical and very challenging. And this is why it was so important for us to get the enthusiasm of the Eskenazi system to let us into the FQHCs. They have already had some of their providers go through a lifestyle medicine program, and they are sort of spread out through the FQHCs. And those are providers that we will be working with in this effort, and who may already have great enthusiasm for this challenge. And so their involvement is critical. And I like to talk about this as involvement, not engagement. We really need their deep involvement in the process, not just that they're willing to experience something, but rather they're really key leaders in this planning process and the design work, as would be the patients or a coach or a dietitian. So that's critically important. I don't think I need to say more there. And you can do some design stuff to make things more engaging, but not critical. Okay, so I am going to have a good 10 or 12 minutes for you to give input. This is some challenges that I put up here from my experience here, but also there's a nice paper by these guys. One of these, Rich Holden knows one of these guys, and they're at Notre Dame. Is it Card? Yeah, so Card is actually at Notre Dame, and Rich Holden has a connection with him. But they have a nice paper that talks about the challenges of Plan, Do, Study, Act cycle, and they make the case these are useful even for very complicated projects. It's just about execution, and that's what I'm hoping for, some input into the planning and execution of this process. We have internal funds to get started on data collection in the FQHCs, and that data collection would be used as pilot data on a resubmission of the cohort study, which is likely going to be needed, but also would allow us to get started with these PDSA teams in the very near future. And we can learn in the first efforts with the team. But I know there are some cultural differences between Eskenazi or a healthcare system and Regenstrief that can create challenges. We're in different physical space. We have different demands all day long. Time efforts are a big issue. My experience with these kinds of things is that we have very, I call it thin effort. We have people 10% on 10 projects. And when you're intensely trying to solve a problem, that's really a barrier. So you can see the notes up here, and I think I'll stop, and hopefully you have some input and thoughts. Now, if you're like me and you're kind of an introvert and you don't like speaking up in a crowd, just send me an email or come see me. I'd love to talk to anyone about any of this. If you want to talk more about the theory or you want to talk more about the plan, just please come find me. I'm on the 4th floor, or my email is dannyclar@iu.edu. Okay. Questions? Comments? Nicole?
So in the design, and thank you for putting up the building blocks. I'm curious, like, are there sort of also pieces to the the theory of behavioral change that are part of it? So I mean, I know you talked about the environment and the nudges, but what about sort of people's willingness? And so, have you talked sort of about the sort of stages of ready to sort of say make a change to salt intake? Or
Right. Yeah, that's assessing traits is where I would put that. And yes, it's critical. If you think about the re-aim model, for example, another beef I have about our work, any of our work in the behavioral sciences, is that we're selective in who gets in. And then a small fraction of those who get into the behavioral trials actually complete. And so you end up with, 5% impact or something. So understanding where someone is, what are their resources, what are their limitations, what are their life challenges. Someone with food insecurity shouldn't be in a weight loss intervention. So, we have to do a lot better job about thinking of those kinds of things. And there's a lot of folks here. I know you're doing some stuff on social determinants of health and other things that could be really critical for helping to sift through efficiently to find when persons are ready to address a particular exposure and when they're not, and when something else should be addressed, like a basic need. Rich?
Yeah. Just two thoughts. One would be, you use the term biomarkers, but actually for someone like me who doesn't work in that area, it might be useful to have a list of what you mean by biomarkers, and you might just give a few examples now. I mean, I think I have some thoughts about it, but you talked about a lot of different things. And so, and the second thing is, what ideally are you looking for? Because it sounds like one thing you're doing is you're submitting for a cohort study, and it almost sounds like more of an epidemiologic study where you're going to enroll a bunch of people and then 3 years later. But then you also framed it as you may want to move on to interventions that make a difference around something that a person can change. And so are you looking for someone who's studying a condition and say, well, you serve as a core and collaborator with this toolkit, and we can focus on this condition with that toolkit?
Yes, I'm maybe it's too big of a plan, but I'm hopeful we can run the cohort study while also helping these teams use whatever whatever portion of the data they would use to create these better, more efficient, more effective behavioral interventions. I might not be understanding your question.
Yeah, so if you look for other people who might be interested in this, they may be, well, studying pain, studying stroke self-management, studying,
Yeah.
I mean, you mentioned traditional things like diabetes and things like that, but it would be someone who's studying a condition and may want to move on to a behavioral intervention and then use this biomarker sort of methodology?
Right. So, yeah. So in this case, I'm hoping we can have an impact by helping the health system work in areas they think are priority. So rather than me knocking on the door and saying, I really want to do something about high-fat meals, I would like them, I would like to say, here we have these resources, these skills. We think we can run this structure with you. Where would you like us to help? And I think given our somewhat generic skills in behavioral science and data management and all of these new tools, there's a lot of areas where we could be useful.
Well, without the last question, just the thought came to mind. So for the next 3 to 5 years, those who are working in the space of opiate addiction or addiction and substance, and they're trying to find behavioral interventions for it, you could see a place for this as something that could collaborate? Okay.
If there's a lead, yeah. I mean, I'm looking for content leaders. Mike Weiner's been the content leader for hypoglycemia. Who would be the content leader for hypertension, or who would be for opioids, and how much capacity do we have to help and assist, and can we run this structure? Rich.
So I guess maybe you know better, but I can't think of a single behavioral sciences model that's event-based, like your crankshaft model. And so what you're proposing is really new in terms of the study of psychology and behavioral science, and yet very compelling. So I guess I have a two-part question. The first is, if we're talking about event-based models of behavior, will that garner any support from the established psychologists and behavioral scientists, or will they dismiss it because they've never been able to measure event-level phenomena? And then I guess the other is that maybe there's a little bit of a discrepancy then with these PDSA teams that are not event-based interventions. They're coming in after weeks or months of event-based data collection that almost describes a person's traits, rather than kind of these individual, they saw something on TV that angered them. How can we calm them down, like that moment, rather than wait 2 weeks and say we're going to give them better television programming?
Okay, Rich, can you summarize your two questions? I can't hear all of it.
Yeah, well, the first one is more kind of out of curiosity, whether you believe there's anything like the crankshaft model out there in the basic sciences. And then the second question is whether the PDSA teams are intervening in the same fashion that you see behavior playing out, which is responses to discrete events during the course of the day, versus, I think, the way I imagine it, the PDSA teams are coming in to deal with things like, every week, every 2 weeks, every month, and not responding to, what you had for breakfast, or what music you heard in the ICU today.
So the first one, yeah, I agree. I have not seen a behavioral model that crankshaft model. I don't. Somebody's probably picked it that way. Other people pick it the same way, but I haven't seen it. And on the PDSA teams, we're coming in saying we can help with this kind of data. I think somebody wanted to use no new kind of exposures data or time data, would we still help? I would have to think about it, because really this is a pairing of this cohort project, which really depends on putting data like on digital marketing, not bio. And so I'm not sure the answer to that.
I guess maybe, how about this? Could phase 2 be where these devices that are strapped onto a person, one day when they have elevated, glucose levels and their phone detects that they had a recent eating event, that the phone sends them a message. I'm talking about the JEDI concept, right? The just-in-time adaptive interventions, rather than relying on these clinical teams who can come out every once, 2 weeks maybe.
Absolutely.
Dan, can you go to the mic, please?
More likely it's going to be some combination.
So Dan, just picking up on a couple of those comments and thinking back to where you started, just to hone in for a moment on the aspect of this, which is about digital markers. There's a lot of unpacking to do there in terms of that concept. I don't believe, at least I'm not aware of any group or organization that is emerged as the sort of de facto leader in identifying, validating, being able to actually define and put some real operating characteristics around particular digital markers. And as we continue to traffic in this kind of information in the initiative you're leading and many of the ones we have ongoing, it seems we're in a wonderful position with our expertise and our resources to be able to emerge as a leader in terms of defining the meaning of, the implications of, the prognostic and preventive and sort of operating characteristics of these digital markers. There's work to be done there. So I guess my question is, in the larger context of what you're planning and proposing, is that a part of it to sort of define and develop better knowledge and parameters and understanding and meaning for those digital markers? Because that in and of itself, I think, is a multidisciplinary activity that we could be well positioned to lead in. But I don't know where that fits into your larger frame.
Well, I suspect your thinking is beyond mine on that topic. There's going to be a tremendous amount of work just getting the data collected, making sense of it, and chasing a few interventions. I would imagine what you're talking about would emerge if we were successful in a few rounds of this. That kind of thing is going to emerge. But I also have in the back of my mind that this stuff is changing so fast. These tools, and if probably by the time this study is funded, we have to change the glucose meter that we would be using because there's a different, better.
Well, it strikes me that it probably is in both directions, where the work that you're proposing to do here would inform. You're collecting a lot of the data, associating it with behaviors, outcomes, other actions that would inform the meaning of those digital markers that could be of benefit to others, but also without having more definitive understanding of what is the meaning of said marker. Collecting it, storing it, analyzing it is going to be challenging in terms of the specificity you need. So I think you're right that there's probably a complementary effort here, but it's something I think as you're planning this that would be worth delving into more, because I do think that's one of the biggest challenges we have right now. There's a lot of money being invested, not just in academia, but certainly in industry, that dwarfs what we're investing in terms of capturing, storing, and trying to analyze these markers, but their meaning is elusive.
Yeah, so I mean, you might think about that as another sort of module kind of thing. Do we have some consistent sense making that comes out of these tools? And some of it may not be useful, and others of it may be very.